Sophie Huddart is a tuberculosis epidemiologist and a postdoctoral scholar in the Pulmonary and Critical Care Medicine Division. She's interested in TB quality of care, especially how it influences the long-term outcomes of TB patients post-treatment. And we're really glad to have you, Sophie, and appreciate you coming in to do this lecture today. We have people who are both present in person at the Children's Hospital, and then we'll have people who are joining by Zoom as well. So with that, I hand it over to you.
Okay, fantastic. If at any point anyone has questions, I've turned off the video because it distracts me, but just go ahead and shout and interrupt me, and I'd be happy to answer questions. And then I will also admit that I'm sort of the poor man substitute for the person who normally gives this lecture, which is my colleague, David Jagannath, who we work together and share an interest in digital health, but he's actually a pediatrician, so he's kind of perfect for this lecture. But I've done my best to kind of give the special pediatric considerations for some of the things that I'm going to talk about today. So my hope today is to kind of talk generally about the promise and the hope for digital health tools in the global health realm. And then I'll walk through some concrete examples of digital health use in tuberculosis, which is what I research. And then whenever possible, like I said, I'll highlight the special considerations for pediatric and adolescent populations. So first, as a premise of digital health, both the World Health Organization and the FDA actually take a really wide view of digital health, and it can include things like IT that facilitates digital health, telehealth, personalized medicine. And those are all wonderful areas of research, but I just want to highlight that today I'm going to talk mostly about wearable technology and mobile or mHealth. So here's kind of the hope that we have for digital health, and to sort of echo other, big transitions that we've seen in the global health field in the past. And so the example that I'm showing kind of here is a metaphor, allegory, or previous example is that in many low and middle income countries, these countries sort of rapidly went from having pretty minimal phone connectivity to completely skipping over like the landline phase that countries of the United States went through, and skipping directly to having a lot of cell phones, smartphones. And so they kind of, leapfrogged that transition to the point now where countries like India, there are more cell phones than people in the country. There's like incredibly high degree of connectivity. And the hope is, this is a little bit where the metaphor breaks down, is that we can do something similar to digital health. Because there are many settings in the world where quality of care right now is pretty poor, especially for diseases like tuberculosis. And while capacity building and healthcare strengthening are critical, and we really don't want to skip this. This is so important for many, many reasons. But there's sort of this hope that we can alleviate some of the pain of not having these fully resilient healthcare systems with digital health tools, so that instead of having to wait for the system to catch up, we can kind of plug holes in the system with digital health tools. So I'm going to kind of pause and shift and just give a quick overview of Mycobacteria tuberculosis. Was someone jumping in, or is that just like a chair squeaking? Okay, I'll keep going.
Oh yeah, go ahead.
Oh, sorry.
No, I think we're muted. I'll try to see if I can fix it on our end. Sorry.
Okay, no problem at all. So Mycobacterium tuberculosis causes the disease that we call tuberculosis. There are a few different flavors of MTB, but they, in humans, all cause kind of a very similar disease. TB is always spread through respiratory droplets. But TB does not typically impacts the lungs, but does not have to exclusively attack the lungs. And when what I'm showing you here basically is the progression of the disease. So if you have on the left-hand side are two people who have an innate immune response or an acquired immune response. There is a TB vaccine. As pediatricians, you may be familiar with it. It's commonly given to children in high TB burden countries in the world, but it's a pretty crap vaccine. Like, it has some productivity against disease, mostly the most severe forms, but whatever protection it has tends to wear off by about 2 years of age. So some people have acquired immune response, but it's really patchy. So you have someone who's exposed to TB, and maybe they clear the infection. Maybe their immune system just takes care of it. But some people are going to progress to what we call a latent TB infection. And this is where the TB bacteria is sort of in a slow growing stage, often in a granuloma, in the lung, or somewhere else in the body. The person doesn't have any symptoms, And so the TB disease is kind of quote unquote controlled, but it's not been eliminated in the body. And these people can, if we can detect that they have latent TB, can be given preventative therapy, which reduces the chance they'll move to active disease. But that's kind of its own diagnostic challenge. People who are unable to control the latent TB infection will sometimes progress to subclinical TB, where they have sort of non-specific symptoms. They probably don't feel terrible, but now some of the tests would come back positive. They might have a little bit of a cough, and then they move to what we would call active TB disease, where usually our diagnostics are positive. The person is probably, unfortunately, quite transmissible, and it's unpleasant. What was I going to add in here? Usually people progress to latent TB if they're going to progress at all within 0 to 5 years. There are cases of people who have reactivated their TB very late in life, but that's less common. And I'll note here in children, the time from latent TB infection to active TB infection is usually very, very short. Yes, that's just my reminder of myself to talk about latent TB. And we do, again, as I'll highlight here, have preventative therapy for latent TB. And then we do have effective treatments for active TB, but all of that is dependent on diagnosis. So globally, TB in last year's report, which is the most recent report, estimated 10.6 million incident cases, but 11% of which were in children. And you can see here on the map, the distribution, it's largely the middle income countries. India wins the prize for having the single largest epidemic, but there are many countries that are significantly impacted by TB. There are unfortunately 1.6 million deaths a year. TB is almost always curable. These are avertible deaths, but they happen for reasons that I will get into. And there has been, with that 1.6 million, we have now reclaimed the dubious crown of being the leading infectious disease killer of adults worldwide from COVID. There were 2 years that COVID won, and TB is now back on top, which is very dubious. And we have seen actually an uptick in the incidence of TB and the number of deaths due to TB, in part because of health system weakening happening because of the COVID epidemic and sort of resources that shifted from TB to COVID, because TB is really set up to deal with infectious respiratory conditions. But a lot of those were drawn away and focused on COVID. What else was I going to say in here? Okay. So here, what I'm showing you, because I want to highlight a lot of the challenges and why TB, being such an old disease that's completely treatable and costs about $20 to treat, is still killing 1.6 million people a year. What's going on? And the reality is that the quality of care that most patients receive is very, very poor. And one way we can examine that is something called a cascade of care analysis. And this is what I'm showing you here. So this is a cascade of care analysis for the Indian public health sector, but it would look similar in other settings. So the leftmost column is called prevalent cases. That's the kind of estimate for the number of people that have TB that you would hope would wind up being treated for TB in your country. And you can see the first big jump out of this, 2.7 million estimated number of people. You lose a third of people. A third of people will never make it to a TB diagnostic center. They will never make it to a center where they could be diagnosed with TB. We refer to that globally as the missing millions. About a third of all people who are infected with TB, we estimate, will either not be diagnosed or they'll never be notified to a national TB program. And that's a big concern. So part of that is just getting people to somewhere where we could diagnose them with TB. But even if they get to that center, they might not get diagnosed. Not all our diagnostic tools range from pretty good but expensive to absolutely terrible. So we can see people just struggle to be diagnosed, even if they have very clear-cut TB symptoms. Then you lose another chunk of people. Okay, eventually maybe we diagnose you, or clinical suspicion is so high, we just treat you clinically for TB. If it takes a long time to diagnose you, you're not going to stay at the clinic for 3 days while you wait for your results. You're going to go home and you might not come back. So you can lose people between diagnosis and being initiated on treatment. TB treatment takes a minimum of 4 months. That's a relatively new regimen. Most people with drug-sensitive TB are treated with a 6-month regimen, which is a long time to take medication. It is not a pleasant set of medications. Side effects are very common. And we do this fun paternalistic thing where it's called directly observed therapy, but TB patients in most part of the world are required to take their medication in the presence of a healthcare worker. Sometimes the healthcare worker goes to the patient. More often, the patient is asked to come into a healthcare clinic every day, take a pill in front of a healthcare worker, lift up their tongue, show they swallow it, and then they can go about their business. but that is incredibly onerous on a patient. It can cost them their jobs. They already feel like crap because they have TB and they got to go to this clinic. It's just a horrible system. So that's why you can lose people who, even if they start treatment, won't finish it and will not achieve cure. And then I'll talk about this at the end. If the cure was inefficient, or they didn't have the right treatment, or they didn't take enough of the treatment, they may actually go through all of that only to end up having their disease reoccur. So out of the 2.7 million people in this analysis in the Indian public healthcare sector who had TB, we lost, 60% of them at various holes in kind of the cascade of care. And that's kind of a very brief 2-minute overview of why TB is failing people, essentially. So when we're looking at digital health tools, what I'm just going to show you now is this is KNCB, they're a consulting group who works on TB. This is one of their views for how you could use digital health tools to kind of plug the gaps, plug the losses in this cascade of care. So you could have people who are coughing who then have good mobile apps to find a healthcare worker and social media that's supporting them or kind of registering like, oh, I'm coughing, I should go to a doctor. You then have digital tools that really increase the connectedness between labs and healthcare workers who are seeing patients so that test results aren't getting lost, they're transmitted to the patient and the healthcare worker very quickly. Hopefully you have tools that support the clinician in decision-making about, confidently diagnosing that this is TB or confidently ruling out TB. Then additional pharmacy, treatment adherence support, social support, social networks as a form of support for patients, all of that kind of helping to improve this diagnostic ecosystem and support both patients and clinicians during diagnosis and treatment. So this is another way that I can kind of highlight some of the many diagnostic challenges in TB. Our favorite triage tool for pulmonary TB is a chest X-ray. And what I'm showing you here at the left-hand side is a list of high TB burden countries. This is kind of an older paper that I've done, but across the top are some of the key kind of diagnostic tools that we would like to give patients. And then each of those small columns, L0 to L3, represent levels of the healthcare system. So L0 would be like a local healthcare worker or community healthcare worker. L1 would be sort of the local primary clinic, L2 a regional hospital, and L3 like a tertiary or referral hospital, something you might find in a capital city. So our favorite triage tool, the chest X-ray, basically unanimously not available at the healthcare worker level. So your patient's already going to have to go maybe to the local clinic at some countries, or they're going to have to find their way to a referral hospital to get that triage test. So dramatically decreases the chance they're going to get a chest X-ray. Sputum smears, which are a 100-year-old microscopy test that misses 50% of TB patients. That test is cheap and pretty broadly available in countries, but it's not very accurate. Then we have tools, actually, since I've rewritten this, there's drug sensitivity testing, which is very important, but we also use this test called EXPERT, which is a nucleic acid amplification test. We also now use that pretty commonly for diagnosis. The availability of those machines has improved a little bit, but it's still broadly true that you're only going to find that in referral centers or in diagnostic centers, not where the patient first shows up. So basically, if you want to get diagnosed with TB, you have to somehow fall into a fairly established hospital when we know that most people first seek care as close as possible to them, which makes sense. If you don't feel good, why would you be like, oh, I'm going to go on a long trip to the capital city to go see a doctor? You go to your local healthcare worker and they won't have any capacity to adequately diagnose TB. This becomes even worse when we think about children. So children are what we call paucibacillary. They don't carry a lot of TB in their body. They'll still be very sick, but they just don't have a lot of TB bacteria to show for it. Additionally, they can develop pulmonary TB, but they're more likely to develop extrapulmonary TB. So somewhere else in the body, and extrapulmonary TB can be more severe disease, especially if it's something like TB meningitis, which is incredibly rapidly progressing and deadly. So you add to the fact that they're paucibacillary, which means the sputum smear, that microscopy test, they're not going to show up on that. They don't have enough bacteria to show up on that smear, the only test that's widely available. So you're going to miss them if you try and use that as your diagnostics. So again, it's very hard to diagnose them at point of care. Specimen collection, we often use sputum. Adult TB patients who have pulmonary TB tend to cough up a lot of sputum. That's not too hard to get, but children don't. So if you can't get sputum out of them, you might have to do a lavage, which nobody enjoys. There's some research at looking into stool specimens, but in general, specimen collection is very difficult for children. Because of all of this, you have delayed diagnosis, so you're delaying treatment. And this is particularly dangerous in children because, as I mentioned before, the time between kind of being exposed and having a latent TB infection to active TB disease is very short. And if you think, it can take months for an adult patient to get diagnosed, if it's a parent or someone else in their household, that means that child has also been exposed for months. And so unfortunately, this means we often can't treat children quickly enough, and their disease progresses very quickly, and they are more likely to die. Of the children who will die of TB, like 95% of them were never initiated on treatment. It just turns out that they had TB, but we could not diagnose as fast enough. They respond well to treatment. They're pretty hardy, but it's this really diagnosing children. It's just very, very difficult and often very heartbreaking. So let's talk about digital health tools. I'm going to talk in sort of three realms, one in diagnosis, where we'll talk about computer-aided detection, or CAD, for chest X-rays, and then kind of an even more novel one, which is cough and lung sounds as digital biomarkers. We'll talk about treatment support, so kind of more patient-centered ways of supporting during treatment and ensuring people are taking their medications using both digital adherence technologies and digital treatment monitoring tools. And lastly, we'll talk about kind of my pet area that I'm really excited about, which is post-TB support, and whether we can create digital proxies for standard lung health assessments. So first up, this is probably the best established digital health tool in TB, and this is automated chest X-ray reading, or computer-aided detection, CAD. So because we love chest X-ray, we think it's a great triage tool. It's great when it's done well, but the image quality of your X-ray can be quite variable, and in many parts of the world, good radiologists are hard to come by. So it can be very difficult to read these chest X-rays if you're not, basically it has to be done by trained radiologists. Healthcare workers, they just don't have the skill set to read these. However, these machine learning models, where they've just fed in, millions and millions and millions of chest X-rays and tagged them, this person has TB, this person doesn't, the machine learning algorithm figures out what aspects of kind of that lung image indicate TB. And so what these algorithms will do is they'll pop back this pretty figure that I'm showing you, where they've sort of highlighted in red the spots that it thinks are most indicative of TB, and it'll give, you can see sort of it's small on the top there, a score. And it'll say, we have this TB score, and if it's higher than this threshold, then probably they have TB or they should go get further testing. And there are about 10 systems, and they've been pretty well studied. So the WHO a few years ago actually approved of this type of computer-aided detection in those 15 and older. And it's basically said this is as good as a trained radiologist. If you don't have a trained radiologist, it's okay, you can use CAD. The area under the curve is sort of a measure of accuracy, ranges from 0.8 to 0.95, where a score of 1 is perfect, which is pretty good. That lines up about with, if you have a really good radiologist, that's about as well as a radiologist would do. The one thing I'll add, this test, so the CAD, you can also scan in the X-ray films, but it also pairs really well with portable digital X-ray tools. So you can get, they're like this big, they're really portable chest X-rays, and then you kind of take that out into the community and do screening, where you take a digital X-ray and immediately feed it into a CAD program and give that patient a score and say, your lungs look great, or there's something concerning in here, we'd really like to refer you to this clinic for TB testing. Now, the trick is, all of the CAD models I just described were trained on adolescents and adults, and there's reason to believe that they're not going to perform really well on children, both because TB can show up differently and children, shape different, lungs look different, and the algorithm's not trained for that. And for a long time, the roadblock was that we didn't have those, large number of really high quality X-rays to train the algorithm on. But not to worry, my colleague pictured here, David Jackanoff, he's on it. He has a program called Capture, and he's assembling this really lovely database full of pediatric chest X-rays from around the world that have, super high quality diagnostic data behind them. So we can say this one's TB, this one's not TB, and it's hoped that he can develop from that a CAD algorithm that will be approved for use in children. So second, so CAD is pretty well established. WHO approved, it's out there, it's being used by programs. This is a much newer diagnostic that David and I are investigating and that we're really excited by. I think this is just a cool analysis. And it's looking at cough sounds. So what I'm showing you here is sort of the data that we can get from, these short recordings of a patient going, and so on the left, I'm showing you the wave form of kind of the visualization of the sound. And on the right is called a spectrogram. So this is a way of projecting that wave file, looking both at the amplitude and the intensity over time. And so you get this kind of pretty graph, but this is what you can feed into a machine learning algorithm. And what we've seen so far is that there's an early signal that a TB cough versus a COPD cough versus a flu cough versus a COVID cough, they all have unique features, which kind of makes sense because they show up in different places in the lung. They have a different impact on the respiratory system. And while we can't hear that with a human ear, a machine learning algorithm seems to be able to pick up on facets that discriminate those diseases by the sound of the cough. So in our study, which is the PI here is Aditya Katamanchi. The study is called Rapid Research in Diagnostic Development, or R2D2. And so we have this amazing logo, and no one will ever come up with a better logo or study name. So you can just stop trying. R2D2 wins. But what we did is we gave our incredible study participants who had come into clinic, they'd had at least 2 weeks of new or worsening cough. So these are the people who, they didn't all have TB, some of them just had some other respiratory condition, but these are like exactly the people that we would want to be evaluated for TB. And we asked them to wear, I'm showing you on the picture to the right, this like really lovely pocket, and we shoved a smartphone in there. The smartphone was running an app called Hive, which listens to the sounds that are, coming into the microphone, and then it can identify explosive sounds, so sounds that are, two times or more louder than the background noise, and it'll kind of capture like just a half second to protect privacy. That explosive sound runs an algorithm and says, oh, that's a cough, record it, or oh, that's not a cough, it's just a car backfiring or something, let it go. So we asked people to wear these very stylish necklaces for 2 weeks. And we recorded their natural coughs, and I'll talk about solicited or forced coughs in a minute. And when we collected those coughs for 2 weeks, we just looked at something like frequency. How often are people coughing? And we were really interested to see this result. And what I'm showing you here, basically the red line is people who had confirmed TB, like we found the TB bacteria. Green here is people with clinical TB, so they were treated based on clinical suspicion, but all of their TB diagnostic tests actually came back negative. And in blue are people who had some other respiratory disease. They don't have TB, they just had something else that was making them cough. And on the x-axis here, I'm showing you the recording time. So going from day 0 on the left to 14 days on the right. And on the x-axis is a measure of coughs per hour. So how frequently were people coughing? And so what we're seeing here is the red line, the people who have confirmed TB cough a lot more, significantly more than people with either clinical TB, which some of them actually do have TB and some of them don't. We just treated them to be sure or to be safe. And then they cough significantly more than people who don't have TB. So that was an interesting signal. We're like, oh, they like TB people cough a lot. And this is the first time that you really had like hard numbers on how often they cough and when in the day they cough. And so we were like, okay, there's something here about cough. So this work is ongoing, but I did mention the solicited cough. So this, you kind of, when you put it around your neck, you don't get the best quality recordings, right? Because they're outliving their life, and you just kind of get like, okay, they did cough, but the sound is not that great. But which is why we also asked people for solicited cough. So this is where we, put them in a quiet room in the clinic, and we say, can you cough 5 times into the same app that'll record the cough, but just kind of 5 clean coughs really close to the microphone. And then we do the same thing where I'm showing you here, we take the waveforms, and the app that we use can pull out when the cough happened. It can pull out kind of features of the cough, characteristics of the sound. And then we're using that to pick out the aspects, using machine learning, the aspects of the characteristics of those cough that are informative for whether or not the person had TB, and using all of that to develop a prediction model that can take in the cough and then turn out the, yes, I think they have TB, or no, I don't think they have TB. So we have a model in-house that we've sort of worked on, but what we also did, and I think this is really interesting, is we launched an open access data challenge in partnership with Sage Bionetworks. So it's called the Cough Diagnostic Algorithm for Tuberculosis, or CODA TB Dream Challenge. And we took our R2D2 data, plus we have a partner at the Université de Montréal who had data from 2 more countries. And we took all of that cough data for, it's thousands and thousands of coughs for like 1,500 patients. And we just put it online. And we launched a challenge and we said, please come look at our data, try and develop this machine learning algorithm and make a prediction for people. Do they have TB or not? And we'll evaluate how, we kind of gave them half the data to train on and we held back half the data to evaluate how their algorithms worked. And what was really exciting, we had, about 10 teams participate. And the top 3 performing teams met the WHO target product profile, so the target sensitivity and specificity for a TB triage test. So like they just made it into that category of like good enough. We're like, that's really exciting. So the AUCs for all 3 groups were about 0.83, which is not off the charts good, but it's a signal that there is something in cough. And the thing that bowled me over, one of the top performing teams was actually a group of high school students, like they couldn't come to our meetings because they had to be in school. But they turned in this incredibly performing model. They placed 2nd in the challenge, and the future of science is bright, basically, is what I'm saying. So yeah, we did this amazing challenge. We're writing up the results. But if you, in the meantime, here, like this data is publicly available still. You can go search CODA TB Dream Challenge. You can download the data yourself. You can develop your own algorithm. We will evaluate it for you. We're really excited about this approach to kind of see, no one on our team is like a machine learning expert. And so releasing this data into the world and asking people to help us in global health has been a really interesting process. Okay, so some considerations now for children. We had adolescents and adults that we gave those beautiful necklaces with the phone on it, but we had a lot of adolescents kind of tell us, I can't wear this in school. Like, are you kidding me? Like, I can't play sports with this thing on. I'm not going to do it. And we're like, okay, totally understand. That company is now working on smartwatches that can do this, which will be amazing when it's much less, annoying for the patient. Instead of having a phone around the neck, they can just have a smartwatch that is listening for the sound. So we're hopeful for that. But David is collecting this data for children, but there are some concerns. So yes, you can put a little smartwatch or a phone or whatever on a kid. But both, that's a child and they may or may not leave it on, and they might run it through the dirt and they might lick it, they're kids. They might smash it into a wall, in which case it's not going to work very well. But there's also this issue of cough contamination. So again, often children are infected with TB by someone in their household, a parent, someone else who lives with them. And so think if it's the mom who had TB, if she and her child are being evaluated for TB, she's going to be holding the kid feels sick. So if the kid's coughing, then that will get picked up by the kid's cough monitor. But if the mom is coughing and she's holding the kid's cough monitor could pick that up too. And that can kind of contaminate the diagnostic. So there are companies that are kind of working on trying to develop a cough fingerprint, basically, so that once you kind of point the smartphone at like somebody's cough, it'll fingerprint it and only count their coughs versus somebody else's cough. But that's still in development, and that's just kind of one more technological hurdle that we would need in order to kind of feel confident that we're getting good data on pediatrics with this kind of tool. Okay, and this, I really don't have any data to show for. I'm excited about it, but we're still collecting this data. In addition to things like cough, you can also collect digital sound data using lung sounds. So this like weird white wand I'm showing you on the right side, that's actually an e-stethoscope. So you can hold it up against the body. It does this really cool algorithm where it like filters out like the sound of your blood and everything to just kind of isolate the lung sounds. And it figures like your body actually reverberates acoustically and it like filters all that out. So it can just get the lung. But you can hold it on multiple points on the lungs, just like you would do in a physical exam, and ask the patient inhale, exhale, and you can record all that, and that sound can similarly be passed to a machine learning algorithm, and we're evaluating whether that as well can give us information about TB diagnosis. Okay, so that's the diagnostic side. Now I'm moving into kind of treatment support. So I'm again starting with the kind of the most established technology here, and we would call these digital adherence technologies, or DATs. So they support the patient taking treatment adherence, and they sort of provide an alternative to what I described earlier, the directly observed therapy where the healthcare worker has to watch you take the pill and everybody hates it. What these tools can do is monitor either through a digital pill box or maybe an SMS reminder, or just taking a video of you taking the pill and sending that to a healthcare worker. There are alternative ways to kind of demonstrate that the patient at least has put the pill in their palm. Whether or not we take it, some of these tools don't tell us, but we call this self-administered therapy, which is often more convenient and more tolerable for the patient, but we can still monitor whether or not they're taking their meds. So all of these systems will kind of feed into an electronic dashboard that would, if someone maybe for 2 days in a row hasn't taken their medication, or hasn't opened their digital pill box, or hasn't replied to the SMS message, or whatever the system is, that goes in their digital dashboard that they missed the doses, and their healthcare worker will be notified, because maybe the patient, maybe they lost their medicine, maybe they are having side effects and they don't want to take it. What can often happen, we tell patients are told to take these medications with food. Maybe they don't have food, and so they don't know if they should take the medication or not. So a lot of challenges that can just be overcome or made easier by talking with a healthcare worker. I'll talk a little bit more about this particular technology that I'm showing you on the right-hand side here. What this is it's a pill blister pack that's inserted into a paper envelope. And every time you pop a pill out of the blister pack, you open those little windows on the kind of cardboard envelope that you can see. And opening that window reveals a phone number. The patient then calls that phone number and hangs up as soon as it sort of rings. That way it doesn't cost them any kind of data or airtime. But that call is recorded as, I took my meds today. So this tool is called 99 Dots. It's originally developed in India, but my PI evaluated this in Uganda. So the PI in the UCSF side was Aditya Karamanchi, and our PI in Uganda is Achilles Katamba. And they evaluated this 99 Dots technology compared to traditional observed therapy by a healthcare worker. And they found in an intention to treat analysis that it was essentially non-inferior to DOT, which is pretty good to have a patient-centered technology that performs the same as the patient burdensome system is good. But they were actually able to show, when you look at a per protocol analysis, that the patient outcomes were improved among those who use 99 Dots, which is especially impressive because the center already had pretty good treatment outcomes. So it's evidence that this digital adherence technology can improve patient outcomes in addition to being just more tolerable for the patient. So thinking specifically about adolescents, DATs might be a kind of kinder way to treat adolescents, makes it a little bit more manageable, gives them more autonomy, and minimizes their impact on work and school. And a secondary analysis of that 99 Dots trial, just looking at the adolescent data, is forthcoming. So I'm showing you this graph again. This is, again, the cough frequency from those little phone necklaces we gave people. The other thing we noticed when we looked at this is that, yes, people have TB cough more. That's interesting. But obviously, once we've diagnosed these people with TB, they're starting medication. And so you see this like really steep decline in the rate of the frequency of coughing over time. And so I'm like, is that because of the treatment? Like, this is something that we're actively looking at right now is, does cough correlate with treatment markers like colony forming units and time to positivity in culture? And so what we'd like to evaluate is maybe cough can tell us if someone's on treatment that's inefficient or that's not working very well, especially because it takes so long to get drug sensitivity testing done. This could sort of indicate much earlier, hey, this treatment isn't working, we need to switch them to a different one. And so that's an ongoing area of research. Okay, and this last thing I'll talk about, and then yeah, we should have a good amount of time for questions and discussion. So again, this is my kind of personal area of interest, is post-tuberculosis health monitoring. It's kind of crazy in a disease that is as old as this, but it's really only in the past 5 to 10 years that we started thinking about what happens to people after we cure TB. Like, it used to just be like, okay, you're cured, we did it, done. But now that we started looking at it, we see that it depends who you look in, between 30 and 80% of people who've survived TB will have abnormal lung function. And some people, it just kind of keeps getting better after TB, but some people it stays bad, and some people actually decompensate after TB. So it's like a really heterogeneous pattern. And while we focus on the lungs, because TB is often a pulmonary disease, we have also seen evidence that there's increased rates of cancer, cardiovascular disease, pulmonary hypertension, in addition to very well-studied effects on socioeconomic outcomes and mental health impacts. So really, we're increasingly becoming aware that like, just because we've cured someone of TB does not mean we've like solved the problem. So one thing that we're looking at, and what we've written into the guidelines that we wrote based on no evidence, but our best guesses, what we wrote in those guidelines is that we think it's really important that all patients receive spirometry testing after they finish TB treatment. This is easier said than done, since in many high burden TB countries, it is very difficult to find someone who can do spirometry, and then like you don't stand a chance of finding someone who could do like pulmonary rehab on patients. So thinking again, okay, how can we plug this gap? There are tools under development and like an ongoing project that I'm hoping to enroll in the next few months, where you can take a recording either of a cough sound or of someone sort of doing inhalations and exhalations like you would do during spirometry. So, you know, inhaling all the way and then exhaling as quickly as possible. Using the sounds of that or cough, there's early evidence that actually correlates pretty well to spirometry measures. So could we have this like smartphone-based test that either we text the patient or we do when they come into the clinic for monitoring, or we use the sound to say like, ooh, your spirometry levels are a little bit concerning, you have an abnormal kind of lung sound or lung health. And maybe that could target people for earlier intervention before, at the moment, the way that we treat people who have post-TB related health issues is when they become very, very symptomatic, then they show up in these sort of referral or tertiary hospitals. And in reality, it's probably more likely that we can help them if we can intervene earlier. So, you know, could wearable technology highlight dangerous health trends? And the project I'm close to enrolling is mostly in adolescents and adults, but David and I have talked about how this could be really interesting and important in children, because we know that adverse childhood experiences can have really far-reaching impacts on child health. And having a chronic, lengthy lung infection like TB is probably going to do some measurable damage. So can we better understand what risks children face if they have TB early in life? And can we figure out which children would really benefit from additional monitoring or intervention to try and mitigate the effect of that early TB exposure? And this, I'll just mention this app here on the right, I think still has like the public link up where you can test it out. It's called SWASA, SWAASA, and their pitch is basically that they can listen to you cough for 10 seconds and kind of feed you back this dashboard of lung information. So it's sort of like, eventually they want to work on an estimate of spirometry. Right now they kind of call it like normal, abnormal, but with repeated measures, you can also kind of see trends in your lung health. So to wrap up, and then I would love to discuss or hear anything that anybody has to say, but the hope is that digital health tools can move high quality care closer to patients. We also hope that these digital health tools will be cheaper and less invasive than currently available diagnostic and treatment support tools. Within TB, we currently use digital tools and are evaluating new ones for diagnosis, for treatment, monitoring, and support, and for post-TB monitoring. However, there's a critical need for high quality data to both develop and evaluate these tools, especially in children and adolescents. So there's my whirlwind overview, and I would love to discuss with you. Oops, I turned my video off. That's not what I wanted to do. Okay. If anyone in the room is speaking, you're still muted. Oh, there you go.
Yeah, sorry, just checking, but you couldn't hear us. Thank you so much, Sophie. I'll open it up to questions. Anyone on Zoom, and feel free, if you're not in a place where you can come off mute, if you want to put anything in the chat. I have a question for you, Sophie. Mm-hmm. And you know, kind of reading between the lines, it seems like you think that the move towards digital health is really what's going to make that difference for the missing million in terms of the diagnostics. I wonder, could you comment on, you know, to your other point that TB has been around for so long and has been, you know, newly again the #1 killer in the world. Do you think that this the diagnostic tools that we're moving towards, is that enough to change that overall kind of like arc for human disease? Or do you think there's more to it than digital diagnostics?
Yeah, so you've accidentally hit on a little soapbox thing here. So another thing I'm really passionate about is advocacy around TB, and especially empowering patient advocates, survivors, and communities directly impacted by TB to really make some noise about this. We often compare ourselves and fail in that comparison to the advocacy by people in communities affected by, like people living with HIV and communities affected by HIV, AIDS. Like that level of advocacy is incredible and effective and loud. And TB has just never gotten there. We're a very paternalistic approach to disease historically. And all of that is a long way of saying what's really wrong with TB is it's a give a damn problem. Like we don't need new technologies. We do have technologies that currently could diagnose people. We can treat them efficiently. It's a question of political will, attention, and funding. So, we really think of these digital health tools as sort of like plugging your finger in a dam. Like it's not the ideal solution. The ideal solution would be for governments to just invest in better, wider screening, and give TV programs money to do what we know works. But sometimes it's easier to get people excited about a smartphone app than about training nurses to do TB screening. So that's kind of a bit of a pessimistic answer. I think they're part of the solution, but I think it's a multi-pronged approach. And the most important prong, in my view, is supporting patient advocacy and demanding attention and demanding better for people in communities affected by TB.
To follow up on that, what do you think the historical context is to the lack of engagement from funders and government? What are your thoughts on how we ended up in this conundrum?
So if we take the United States, for example, the vast majority of the reduction in TB cases actually happened before we had any sort of antibiotic or treatment for TB. So all pre the 1950s, and is largely linked to improved nutrition and improved housing. TB is a bully of a disease. It affects people who are malnourished, who have poor housing, who are socioeconomically disadvantaged. There's a joke that like the best vaccine for TB is adequate food. This actually really great paper out of India was just published in I think Lancet, looking at food supplementation and then the risk of developing TB. And people just need food. Like it's so in the United States, the reduction in TB happened mostly just due to increase in socioeconomic status, which then led to these improved living conditions. And because of that, we stopped caring about TB in high-income countries because it just sort of went away on its own. But that's not the reality for many low and middle-income countries, for the reasons that I just mentioned. And sorry, I might have moved away from your question but I think the historical context is we stopped seeing it, so we stopped caring about it.
That's helpful. Thanks. Other questions from people on Zoom? In the room.
And one other thing I can mention, I didn't present slides on it because it's not my project, but David has a really interesting project domestically looking at incorporating kind of better electronic medical record prompts for LTBI testing for children. So if Epic ever prompts you with hey, we should evaluate, they've come from a high-risk country, we should evaluate this child for LTBI, then you can thank him for that and for any useful information that pops up for you.
That's great. Thank you so much, Sophie, and we appreciate you coming in to talk about the work that your group is doing. For those who are on Zoom, I'm going to put an evaluation link in the chat. If you wouldn't mind just taking, it's honestly like 3 questions long, it's super short, but we really value your input, and we use it every year to revamp the Global Child Health Lecture Series. There is a question in the chat from Barbara. What about the interaction with HIV and TB? And I don't know, Barbara, if you want to, is there more to that, a particular interaction, or from a political standpoint, or from a medical standpoint, or diagnostic?
I think I can also probably guess at what they're getting at. So TB and HIV in many parts of the country are syndemics. So, for example, in South Africa and other similar countries that have a high rate of people living with HIV, about 80% of people living with HIV will experience TB at least once in their lifetime, and about 80% of South Africa's TB patients are people living with HIV. So HIV, TB is in these areas is like one of the ways that people get diagnosed with HIV is because you come with TB, they screen you for HIV, and that's why. The kind of immunosuppression that HIV does makes you just so likely to get TB, whether it's that reactivation because you're moved from latent to active disease because your immune system can no longer suppress the infection, or you're just very susceptible if you happen to be exposed to somebody who has TB. So some countries like South Africa do a really good job about marrying those services together and ensuring that people are cross-screened for both conditions and support them to take the medications together. Some countries do not do a great job. Ideally, we would like anyone who is newly diagnosed with HIV and then kind of recurrently thereafter to be screened for latent TB disease. Because again, we can treat the latent stage and make it much less likely that they will develop active disease. So people living with HIV, particularly if it's not well controlled, are unfortunately much more likely to die from TB. So it's a very important interaction. It's almost a whole different beast how you treat it. But countries like South Africa, I think, do an exceptional job. Some places the services are still very siloed, and so it's very difficult for patients to get both conditions kind of treated in convenient and acceptable ways.
Thank you very much, Sophie. If there's
My
any
pleasure.
other last questions, feel free to jump in now. Okay, otherwise, thank you for your time. We really appreciate it. And thanks for educating us on the digital diagnostics and TB.
Yeah, thanks so much for having me. Enjoy the rest of the series.
Thanks so much. Take care.
Thank you.
Bye.